So I'd like to present our second speaker for the session. Dr. Patrick Kennedy is a consultant hepatologist at Barts Health NHS Trust and a professor of hepatology at Barts and the London School of Medicine and Dentistry. He is the chair of the British Viral Hepatitis Group and the former lead for the British Association of the Study of Liver Diseases with special interest group in the hepatitis B virus, and is a member of the WHO Guideline Development Group and the ESL Clinical Practice Guidelines. So he's going to enlighten us about are we close to hepatitis B virus cure? Dr. Patrick.
Thank you very much, Chairman, organizers. It's a real pleasure to be here in Kuwait, and I'm very grateful for the invitation and the opportunity to speak, especially to Mo, of course, who was with us in London, and Hiba for kindly arranging my visit. Good. So, very short answer to are we close to a cure of hepatitis B? Unfortunately, not that close, I would say. And I think for the general population listening to this is what they want to know when you consider where we were with hepatitis C and hepatitis C cure. So I'm going to give you a little bit of an oversight as to where things are over the course of this talk in terms of cure. So, first of all, chronic hepatitis B, I think for the non-hepatologists here, the gastroenterologists, when they think about chronic hepatitis B, this is what I would think about, because hepatitis B is the leading cause of primary liver cancer globally. And more worrying than that, by 2040, we expect the numbers of liver cancers as a complication of chronic hepatitis B to double from where we were in 2015. So essentially, we have a 15-year window where we can make some interventions about reducing those number of cancers which are a consequence of chronic hepatitis B. So what I want to do today is to give you an overview of the need for functional cure and how we improve chronic hepatitis B management in the short term, especially if hepatitis B cure is not close. So very crudely, if we just break down the division of risks for progression of chronic hepatitis B and liver cancer into host and viral elements. The host elements here on the left are showing you male gender, age over 40, family history of HCC, and where you're born. You can see there's not many of these that are modifiable, but age is, highlighting the possibility that if we treat patients earlier, we can mitigate the development of liver cancer. If you look on the right, you're looking at the viral and disease factors which are associated with the development of liver cancer. They range from cirrhosis, elevated HBV DNA above 2000 IU, elevated ALT, as we just heard about in the previous talk, and then the development of e-antigen-negative chronic hepatitis B, prolonged time to e-antigen seroconversion, and genotype C. Again, many of these factors, viral or disease factors, are also modifiable by treating patients much earlier. So you will see the direction of my talk, and what I'm talking about is the potential for reduction of thresholds of treatment and treating patients much earlier to prevent the development of chronic hepatitis B. This is a paper that we published in 2016 in Gastroenterology, and it's a very important paper because it highlighted really for the first time HBV DNA integration and clonal hepatocyte expansion in very young patients. And what this slide here shows you, very good. In patients as young as 15, 17, 18 in my clinic in East London, when you study these patients, when you study their livers, we're able to identify clonal hepatocyte expansion already in the liver, which is suggesting that from the second decade, there's already integration and already the mechanisms are already underway for the development of liver cancer. And then it won't come as a surprise to you that the maximal clone size shown down here are in those patients who develop liver cancer. Very simple message. The longer you have clonal hepatocyte expansion that we don't do anything about over decades, these are the patients who go on to develop liver cancer. And over the last, I would say, 5 to 10 years in chronic hepatitis B, the major focus in research and the major interest has been around this concept of HBV DNA integration. And this is it here on the bottom. This HBV integration in chronic hepatitis B is a direct mechanism of liver cancer. And as you heard earlier from Manira, that the top, the concept of inflammation, development of fibrosis, development of liver cancer, that pathway, that more indirect mechanism of liver cancer, is also present. So you essentially have two pathways which are underway for the development of liver cancer in chronic hepatitis B. And that's why we need to think more about interventions, about how we manage chronic hepatitis B. You heard at the very outset that I was involved in the recent guidelines for WHO, which are now published, and the INT'L guidelines, which will be published in Amsterdam this year. But this is a really telling slide, because what it shows you, that if you take the various guidelines, INT'L, ASL, DAPASL, and INT'L is the closest of these three to update their guidelines, which will be published this year, you follow those guidelines, you can see the number of patients who are developing liver cancer outside of guidelines for the use of antivirals in chronic hepatitis B. That's pretty worrying to me, and it's especially worrying if I lived in Asia and I was being managed under the APASL guidelines. So this really, to me, is a failure of the guidelines, which we hope to address in the coming round of the updates. These are data that you'll all be very familiar with. This is from the REVEAL study. This goes back many years. Very well cited study, and it's a very simple message, that the higher your HBV DNA, the higher your HBV DNA as it increases, this is the higher your risk for development of liver cancer. So effectively, moving away from those historical concepts, if the virus is high and the liver enzymes are low, that you're not at risk of liver cancer. It's been shown again and again and proven in, I would say, emerging data that we need to intervene if we see high levels of virus, and of course reducing the threshold for what we consider high level of virus should protect the individual from development of liver cancer. And this is a really important paper published by colleagues in Korea and got a couple of years ago now, but it's a seminal paper because what it shows us is that if you take this concept of high HBV DNA here in the antigen positive cohort, so those referred to as immune tolerant, versus immune active patients who are treated with antiviral, you will see that those patients who are treated versus those patients who are observed are doing better, even though we thought historically that this immune tolerant patient didn't show any evidence of disease progression. So if you look at the cumulative incidence for the development of decompensation, liver transplantation, or the development of liver cancer, those patients with immune active disease and treated earlier are clearly doing better every time. So what about treatment as prevention, or what I call it as a bridge to functional cure? Because we all know that we are not that close to development or having access to curative treatments in our clinic. So we need to improve the management of chronic hepatitis B patients, so we're avoiding or preventing the sequelae of chronic hepatitis B and the development of liver cancer. This is a really important paper published in Gastroenterology by Hugh a couple of years ago. And what this paper shows us very nicely, picking up on some of the work we'd done earlier around integration, is that when you treat these patients, so we're looking at patients receiving placebo versus patients receiving tenofovir, you will see that we're able to modify the course of the disease. By the use of antivirals, we're able to reduce or decrease the number of viral integrations by more than threefold. This is showing us directly that the use of NUCs, widely available in the clinic, is able to reduce not just viral load, serum ALT, reverse fibrosis, but also reduce the amount of integrations. This is another important paper published by MF Yun, good colleague and friend of mine in Hong Kong. This is published by his group, again taking the similar work that we did around clonal hepatocyte expansion and showing when you treat patients, as you would expect, you're able to reduce HBV DNA, as we know, reduce intrahepatic HBV DNA, reduce cccDNA, which classically we can only measure in the liver, but really important down here, also able to reduce those clone sizes that we get, which really are evidence of or markers for the development of or production of HBV integration. And this brings us very nicely to data from HIV. If you take HIV cohorts, as we're all very familiar with, they get treated very early on. There's no waiting around or monitoring of the disease. And when you treat these HIV cohorts and HIV hepatitis B co-infected cohorts, you will see that they're doing significantly better, shown here in red. There we go, if we just get the pointer, shown here in red, versus the HBV mono-infected patients who did not receive treatment until much later in the course of the disease. Again, simple take-home message, reducing the threshold of treatment, starting treatment much earlier, leading to much better treatment outcomes. So as I said, we're not that close to having a cure on chronic hepatitis B. So if we're not cured, we need to adjust our management or improve management in order to prevent the development of the complications of chronic hepatitis B, such as liver cancer. These are the various guidelines. If you start at the bottom of this slide, WHO, which was published last year, the Chinese guidelines from 2022, completely removing the barriers towards treatment, treating many, many more patients. PASL and NASL will follow the INT'L guidelines, which, as I mentioned earlier, will be published at INT'L in Amsterdam this year, I hope. Just to give you a very brief overview of the WHO guidelines and the Chinese guidelines, suffice to say, if you're looking at markers of fibrosis here, such as APRI or FibroScan of greater than 7, you can consider treating patients with HBV DNA above 2,000 IU in the presence of persistently normal liver enzymes, or where there's evidence of a HBV DNA detectable but below 2,000. So you can see that the guidelines are all moving to much lower thresholds for considering and offering patients treatment. And if you look at the Chinese guidelines over here, simple take-home message here for you is if you've got a patient who is over the age of 30 with a normal ALT, but any detectable level of HBV DNA, any detectable level, you can offer this patient antiviral therapy. And this is where the field is now moving towards. So, what are the latest clinical trial data to really bring you up to speed with where we are in terms of achieving functional cure on chronic hepatitis B? I'm going to start with this drug. It's a GSK antisense oligonucleotide called bepirovirsen, shortened to Bepi for all of us to make it much easier. And I'm starting with this because this drug is the drug which is already in phase 3 trials, and you're going to hear probably most about this drug over the next, I would say, 12 to 24 months or beyond. And basically, this is, as I said, an antisense oligonucleotide. It's targeting all HBV RNAs, but we also know that it's got a TLR8 type mechanism in it, so it's got some innate kind of modulation that we see with it. And this is the standard dose, Bepi, 300 milligrams administered once weekly for courses of 24 weeks in terms of the trials that I'm presenting here. Very, very quickly, I'm going to show you these data. They're pretty simple to look at, but if you look at 24 weeks off treatment with HBV DNA suppression and surface antigen less than lower limit of detection, we're achieving surface antigen loss in about 9% of patients. So just bear that number in mind. Surface antigen loss in about 9% of patients. That would effectively what we're considering is functional cure here. Moving forward, I want to show you that this drug is effective in both e antigen positive and e antigen negative patients, but probably don't put too much stock in that for a moment, because now I want to show you over here that this drug is most effective where the surface antigen titer is low. So a surface antigen titer of less than 3 log, which is at less than 1,000 IU, you can increase that surface antigen loss rate up to about 20%. But conversely, where the surface antigen level is much higher, you can see that the surface antigen loss rate reduces. Now, we're talking about functional cure. We want to know about the sustainability, the durability of this outcome. Now, let me show you the data here. So you get to 24 weeks of treatment with Bepi, and you're getting surface antigen loss rates of up to about 26%. But as you follow up these patients off therapy, you can see that the surface antigen loss rates are diminishing, so you're getting zero reversion of surface antigen. So how durable are these treatment outcomes? How durable is this functional cure with this specific agent, Bepi, from GSK? Now, I want to show you data from Arbutus, and this is really just to give you an idea. These are data presented at ASLD in San Diego in November. I want to give you a sense of the complexity of the treatment strategies to achieve functional cure on chronic hepatitis B. So, imdusiran is an siRNA, and this trial, I'm going to give you a very brief overview. This is an siRNA used in virally suppressed patients on NUC. So these are patients in your clinic already virally suppressed. They receive an siRNA, then they go on to receive a therapeutic vaccine plus a checkpoint inhibitor, nivolumab in this case, low-dose nivolumab in this case, and they remain on the NUC. You can see these are patients on a NUC, virally suppressing, receiving an siRNA, receiving a therapeutic vaccine, and then a checkpoint inhibitor. This will give you a sense of I would say, the barrier that we need to overcome to achieve functional cure in chronic hepatitis B. But I do want to show you this. So siRNA's antisense oligonucleotide, here you can see these drugs are very good at reducing surface antigen. And you can see the rapid reduction in surface antigen in these patients over 24 weeks. Now as you move out, you will see in this black line here, you'll see the benefit of the addition of therapeutic vaccine. It's a Chaddock vaccine with low-dose nivolumab. And you can see slight divergence here in terms of greater surface antigen reduction and loss in those patients who are receiving this very complex regimen of drugs. Finally, I want to finish on these data, really, which I think are moving us into that era where we saw with the DAAs and hepatitis C, where the changes or reductions in surface antigen are really at a point where we're beginning to sit up and go, these are impressive data. So these are data from Osprey Bio presented at INT'L this year. Again, I want to show you that this is an antisense oligonucleotide. In this case, it's a novel unconjugated antisense oligonucleotide, and it has some difference to the GSK compound in terms of this RNase-dependent and messenger RNA degradation, RNase-independent mechanisms to achieve surface antigen loss. There are two doses that were tested in this study, a 300 milligram once-weekly dose and a 225 milligram once-weekly dose. Almost all the data that I'm going to show you here are 24 weeks on treatment. Now, I said to you to remember that number from the GSK, from the BEPI study, surface antigen loss rates of 9%. This is a similar but not the same antisense oligonucleotide, and Osprey Bio have shown that at the 24 weeks end of treatment with this drug, we're achieving 52% surface antigen loss, and on the higher dose of the drug, 300 milligrams, we're achieving 69% surface antigen loss. Granted, this is not off-therapy data, but these are data which are completely changing the chapter in what we're looking at in terms of achieving functional cure. These are really a major shot in the arm for the functional cure program in terms of going on to achieve cure in chronic hepatitis B. Interesting data also, just to highlight to you, that most of this surface antigen loss is actually being achieved at 8 to 12 weeks of the treatment regimen. So this is important also. We're able to determine, are patients achieving surface antigen loss, how quickly, as I'm showing you here on this slide, 8 to 12 weeks, most patients will achieve this surface antigen loss or seroclearance of surface antigen with just slight increases as you go out to this 24 weeks. On the right of this slide, important data also showing you the development of surface antibody or the emergence of surface antibody. We think the higher the surface antibody, the quicker we get up the surface antibody with higher levels, this will lead to more sustained durability of surface antigen loss in these patients. Really fascinating data. This is something you're going to be hearing a lot more about over the next 12 to 24 months. So it'll be really critical for us all to see where this data goes in terms of achieving functional cure in chronic hepatitis B. That leaves me with my concluding slide, just to wrap up. Are we close to a cure in chronic hepatitis B? For me, I've seen progress year on year over the last 5 years, I would say. Are we close? We're not there, but we're definitely making good progress towards functional cure. The key drugs that you're going to hear about over the next year to 2 years to 3 years are the antisense oligonucleotide, the Osprey Bio product, and BEPI from GSK that I just talked about, but also siRNAs, because we're already running a study in my institution where we're combining the siRNA with the antisense oligonucleotide. A big question in chronic hepatitis B, unlike hepatitis C, which is an RNA virus, and we think we can manage it with antivirals, with chronic hepatitis B, we still think we need some degree of immune modulation. What is the best immune modulator? Is it a checkpoint inhibitor? Is it a therapeutic vaccine? The jury is still out on this in chronic hepatitis B, and we don't have the data to say what it is. Interestingly, over the last 12 months, 18 months to 2 years, we've been seeing all the drug companies using pegylated interferon as the immune modulator of choice when combining with antiviral agents. Remember, we're not there yet in terms of achieving functional cure of chronic hepatitis B, but one thing we can do is move in the direction of the field, lower treatment thresholds, treat more patients with antivirals, broaden treatment access, making sure that we're treating patients much earlier. And this is the bridge to functional cure that I was talking about earlier. Thank you very much for your attention.